like to thank the conference organizers for inviting me to speak with you about optimizing the management of early stage triple negative breast cancer. These are my disclosures. So I think we could suggest that for triple negative breast cancer, we've largely based the treatment on what it's not. So it's not ER positive, PR positive, or HER2 positive. And so historically, we've thought that there's not a target in triple negative breast cancer to go after therapeutically. And so the mainstay of treatment for early stage triple negative breast cancer has largely been chemotherapy. And we know from a number of randomized controlled trials, notably the NSABP B18 and B27, that the outcome is the same, whether that chemotherapy be given in the adjuvant setting or the neoadjuvant setting. Now, I think there's been a trend to giving chemotherapy in the preoperative setting for a number of reasons. We know that patients that experience a pathologic complete response have an improvement in their event-free survival, shown here in a figure from the meta-analysis by Cortazar et al. And for those that have residual disease, we know that additional treatment can confer an improvement in disease-free survival. And this, of course, is data from the CREATE-X trial that showed a role for capecitabine for patients with triple-negative breast cancer with residual disease after neoadjuvant chemotherapy. Now, most of the early chemotherapy regimens were anthracycline and taxane based. There's also been a number of studies that have looked at the benefit of adding carboplatin, JPAR-60, CALGB 40603, and the Brightness trial. And what we know is that the pathologic complete response rates without platinum are approximately 35%, and with the addition of carbo, increased to greater than 50%. With that said, the impact on EFS and OS is unclear. I think in order to further move the needle with respect to treating triple negative breast cancer, we need to appreciate the heterogeneity of these tumors. In fact, there was an initial effort, I would consider this a landmark study from Lehman et al., looking at 587 triple negative tumors where they did a transcriptomic analysis and identified 6 subtypes with unique gene expression and ontologies. Subsequent work from this same group actually identified that the immunomodulatory and mesenchymal stem cell-like were in fact not independent cell intrinsic subtypes. Rather, they were enriched in triple negative breast cancers with high numbers of TILs or stromal cells, respectively. On this slide in figure B, you can see the correlation between the immunomodulatory subtype signature and lymphocytic infiltrate. And then in panel C, you can see tumors that were initially categorized as immunomodulatory, but had a strong secondary subtype signature. And so based on this analysis for the IM and mesenchymal stem-like subtypes, they proposed a revised triple negative breast cancer type 4 classification. And so I think where we are now is we are further appreciating the heterogeneity of triple negative breast cancer, that there's cancer cell intrinsic factors and cancer cell extrinsic factors that can serve as targets for therapy. And I'm going to begin on the right with the cancer cell extrinsic features. This is largely the tumor microenvironment, which is characterized by tumor-infiltrating lymphocytes and an endogenous immune response. And of course, we all know now that there is a role for immunotherapy in the treatment of early stage triple negative breast cancer based on the results of studies looking at neoadjuvant immunotherapy. In this table, I've summarized a number of the important trials, and I don't intend to go through the details of each, but I do highlight Keynote 522, which looked at pembrolizumab. This is the schema for that trial. You will recall that it enrolled over 1,100 patients with newly diagnosed triple negative breast cancer, either T1C, N1 to 2, or T2 to T4, N0 to N2, and randomized them 2-to-1 to chemotherapy plus pembrolizumab or chemotherapy plus placebo. Patients that underwent surgery and then completed a year of either pembro or placebo. The trial had co-primary endpoints of pathologic complete response and EFS. At the first report and publication of the trial, the PCR rate in patients receiving pembrolizumab, shown here in green, was about 65% compared to 51% for patients receiving placebo, a delta of 13.6%. It was an important observation that the pathologic complete response rate varied by the nodal status. So it appears that the majority of the benefit was experienced in patients who had presented with node-positive disease. Another important observation in the study is that pathologic complete response benefit occurred whether the patient's tumor was PD-L1 positive or PD-L1 negative. And in fact, in this figure on the right, you can see that the delta, the improvement in the pathologic complete response, was actually greater in patients with PD-L1 negative tumors. At the first report of the trial, they also showed the interim analysis for event-free survival. And at that time, although there was a difference, it did not cross the pre-specified p-value boundary for significance. And so this was after a median follow-up of 15.5 months. They had a number of subsequent interim analyses planned, and with their fourth interim analysis that occurred this past summer, now there was an improvement, a delta of 7.7 months in EFS, and this difference, in fact, did cross the pre-specified boundary for significance, suggesting that the study was positive for both the PCR and EFS endpoints. Looking at the EFS by PCR, I think it's interesting to note that patients that experienced a PCR, regardless of whether or not they received immunotherapy, did well. For patients who did not experience a PCR, it appears that the addition of immunotherapy actually is quite important, with the 67.4% rate for patients who received immunotherapy compared to 56.8% for those who did not receive immunotherapy. I want to turn my attention just briefly to the Impassioned 031 trial because I think the data is both complementary and supportive. So this was a trial similar in the patient population enrolled, early stage triple negative breast cancer, randomized to chemotherapy plus atezolizumab or chemotherapy plus placebo. And we've discussed previously that there's a difference in the backbone, the chemo backbones used, with the KEYNOTE-522 having carbo and the Impassioned 031 having just the taxane and anthracycline. This study was a smaller study. It enrolled 333 patients, and its primary endpoint was pathologic complete response in the intention to treat and PD-L1 positive populations. EFS was a secondary endpoint, but it's important to note that the study was not powered to definitively address that question. So again, with the initial report of the trial, which was presented at ESMO in 2020 and subsequently published in Lancet, we saw that there was an improvement in the pathologic complete response rate, 57.6% for those who received atezolizumab versus 41.1% for those receiving placebo. And as we had seen in KEYNOTE-522, the benefit appeared to be greatest in those who had clinically node-positive disease. And much like we had seen with KEYNOTE-522, the benefit was regardless of PD-L1 status. I wanted to speak just briefly about one additional neoadjuvant trial, the JPAR-DOISE, which is, again, enrolling patients with triple-negative breast cancer, randomizing them to chemotherapy plus placebo or chemotherapy plus atezolizumab. You can see here this chemo regimen does, again, include carbo and Taxol followed by an anthracycline. Patients undergo surgery and then complete 1 year of either placebo or atezolizumab. This study also has the co-primary endpoints of PCR and EFS. The target accrual was 1,550 patients, and the accrual was completed in May of 2021. I've heard that they anticipate PCR analysis and interim EFS analysis to be presented next summer. So with respect to immunotherapy in early stage triple negative breast cancer, we all know that pembrolizumab now is FDA approved based on the improvement in event-free survival in the KEYNOTE-522 trial. And importantly, it's approved for use regardless of the PD-L1 status. The implications of that being that we don't need to test our patients' tumors for PD-L1 in order to justify giving pembrolizumab. I do think that there are a number of important questions that remain. One, of course, is the biomarkers of response or perhaps biomarkers of toxicity. We know that these agents are associated with toxicity, some of which can be lifelong. There's also a question about optimal patient selection. We know that a percentage of patients, about 35% with an anthracycline taxane-based chemotherapy regimen, a bit higher, of course, if carbo is added, will experience a pathologic complete response with chemotherapy alone. So who needs that additional immunotherapy? And this is in part why I highlighted that both KEYNOTE-522 and Impassioned 031 showed that the greatest benefit was in patients with node-positive disease. We need to think about the optimal chemotherapy backbone. And then I think a very important question is whether or not a full year of immunotherapy is required for patients that are experiencing a pathologic complete response. And there are ongoing efforts within the NCTN to design a trial to address that specific question. With respect to biomarkers, I would note that with the approval for all triple-negative breast cancer, regardless of PD-L1 status, that our pharma colleagues, in fact, are not incentivized to identify biomarkers of response. But as I alluded to, and as we're all aware, these treatments are associated with toxicities, specifically immune-related toxicities, most commonly affecting the thyroid gland, many of which can be lifelong. So given the toxicities, I think we as treating clinicians are in fact incentivized to identify a biomarker, both of response and perhaps of that toxicity. I would suggest that there's limited biomarker data available from Impassioned 031 and no biomarker data yet from Keynote 522. But there is one preoperative trial that in fact does have correlative data that has been published. And that is the Nuevo trial, which was conducted by our colleagues in Germany. This was a study that looked at the immunotherapeutic agent durvalumab, and you can see the schema here. At the initial report of the trial, they reported a pathologic complete response rate of 53%, which was greater than the 44.2% in the placebo patients, but it did not cross their pre-specified boundary for significance. So this was technically a negative trial. At the most recent ASCO meeting, they presented a secondary endpoint of invasive disease-free survival. And here what we saw was that after a median follow-up of just about 44 months, the 3-year IDFS rate was 85.6% for patients receiving durvalumab, shown in pink, compared to 77% for patients that received placebo, shown in blue. Now, I would highlight that in this study, the immunotherapy was only given in the neoadjuvant setting. As I alluded to, these investigators have done a number of correlative studies. On the right of this figure, I'm showing the impact of PD-L1 status or the presence of TIL by factor associated with pathologic complete response. And what these investigators found was that PD-L1 expression, the presence of TIL, the tumor mutational burden, and some specific immune gene signatures that they looked at were all associated with response to preoperative therapy, but it actually did not differentiate benefit from chemotherapy alone or chemotherapy in combination with immunotherapy. And so there remains a need to identify biomarkers that will identify those patients who require or respond to the addition of the immunotherapy. I want to touch briefly on tumor-infiltrating lymphocytes, which there's been an abundance of literature now suggesting that they are both prognostic and predictive. On the left is one of the very early figures from a paper published by Shireen Loy and her colleagues, which was one of the first groups to look at the prognostic significance of tumor-infiltrating lymphocytes. And in this initial manuscript, they demonstrated that patients with lymphocyte-predominant triple-negative breast cancer, shown in blue, had an improvement in disease-free survival when compared to the triple-negative patients whose tumors were not lymphocyte predominant. And then in work that was championed by Karsten Dankert and his colleagues, they looked at the predictive value. So this was looking at the impact of TIL infiltration on the pathologic complete response rate. And on the far right of this figure, you see for triple-negative tumors that patients who had high levels of TIL in their tumors, so greater than or equal to 60%, had the highest pathologic complete response rates of about 50%. More recently, data was presented by our colleagues in the Netherlands that looked at the prognostic value of TIL, specifically in young triple-negative breast cancer patients. This was a study that included 481 women under the age of 40 treated between 1989 and 2000. They were all node-negative, so at that time, the patients treated in the Netherlands with node-negative disease would not receive chemotherapy. And what you can see here is that their survival could be stratified by the TIL infiltrate, with patients with greater than 75% stromal TILs having a 10-year overall survival of 95%. In additional analyses that were performed by this group, and in a slide I would like to thank Dr. Koch for, they restricted their analysis to patients with T1N0 disease. And what you see here, perhaps seen most clearly in the tables, is the rate of distant metastases and second primaries broken down by the extent of TIL infiltrate. And so what is notable is that for patients with stromal TIL levels of 75% or greater, their risk of developing a second primary, which is 16.7%, is actually much higher than their risk of developing distant metastasis, which is 3%. This is another paper by Park et al. That looked at the prognostic value of TIL in stage 1 triple-negative breast cancer in patients that did not receive chemotherapy. And what they also noted, when using a TIL cutoff of 30%, they could stratify patients with respect to both distant disease-free survival and overall survival. Shown in this table on the right is that data. So this is that analysis by Park et al. Of 74 stage 1 patients. And you can see listed here the 3-year survival rates. On the left part of the table now is data published by Shireen Loy in another paper where she looked at 213 triple-negative breast cancer patients that were node negative, and these patients received chemotherapy. So in contrast to the study from Park et al., the study from Loy et al. Looked at patients receiving chemo. Again, the 3-year survival rates are listed. And what I highlight is that if you look between the patients who received chemotherapy and didn't receive chemotherapy, and these are all patients with high TIL levels, there's really not a difference with respect to those 3-year survival rates. So putting the data together, there is probably an opportunity to identify a high TIL, low risk triple-negative breast cancer. So we know that increased TIL are associated with improved prognosis after adjuvant chemotherapy, with higher pathologic complete response rates with neoadjuvant chemotherapy, and for good outcomes in the absence of chemotherapy for select patients. And it's about 30 to 40% of node-negative, triple-negative breast cancers that will have TIL levels of 30% or greater. So there are a number of groups on both sides of the Atlantic that are developing studies that would use TIL to select patients with a favorable prognosis that might be appropriate for de-escalated therapy. I want to touch on just 2 adjuvant immunotherapy trials to be complete. One is the SWOG 1418 study. This trial, the schema of which is shown on the left, enrolled patients with triple-negative breast cancer who had at least 1 centimeter of residual invasive breast cancer or positive lymph nodes after neoadjuvant chemotherapy. And the patients were randomized to either observation or pembrolizumab. The study's primary objective is to compare the invasive disease-free survival rates between patients randomized to pembrolizumab to those that did not receive pembrolizumab, both in the entire study population and in the PD-L1 positive subset. With respect to the study, it is fully accrued. Approximately 30% of patients remain in active treatment, with the remainder in follow-up, and it's anticipated that we will have the final results in 2023. Another adjuvant trial is the Impassioned 030. And so this is different than the SWOG 1418 trial, which was adjuvant after neoadjuvant therapy for those with residual disease, in that this is a trial that's enrolling patients that undergo upfront surgery. And you can see again the trial schema. It is basically taxane, anthracycline-based chemotherapy regimen with or without atezolizumab. This study, as of the beginning of November, had enrolled 1,959 of a planned 2,300 patients. They have completed the enrollment of node-negative patients and are now prioritizing enrollment of those with node-positive disease. I want to make just a brief comment about my thoughts on neoadjuvant versus adjuvant immunotherapy. This is a nice figure from a review recently published in Nature Reviews Clinical Oncology. So what you see here is that for patients that receive neoadjuvant immunotherapy, meaning they are given the immunotherapy when that primary tumor is in place, the fact that the primary tumor, the source of the antigens, is still in place allows for optimal immune priming. With optimal immune priming, you should see some abscopal effect where the immune system could address the micrometastatic disease that is present. And so what you see here is that will tip the scales in favor of either eradication or what's called immune equilibrium, hopefully with a high rate of cure. In contrast, if we look at administering immunotherapy in the adjuvant setting, this means it will be given after that primary tumor is removed, so the antigen is no longer present. So now we have suboptimal immune priming, less immune response against the patient's tumor, which will, of course, then not tip the scales in favor of the immune system. And so the bold arrow here is now favoring recurrence. So it would be my opinion that we're probably likely to see more benefit by giving the immunotherapy in the neoadjuvant setting, but I, like others, am anxious to see the results of the SWOG and the Impassioned trials. I want to turn my attention now to cancer cell intrinsic features that can be targeted. And so the first one that I'm highlighting here is TROP2. So most of you, of course, are familiar with the TROP2 directed antibody drug conjugate, sacituzumab govitecan. This is an antibody drug conjugate that has the TROP2 antibody linked to SN38 as the chemotherapy payload. This drug was granted accelerated approval in metastatic triple-negative breast cancer in April of 2020 based on the results of a multi-center single-arm study that enrolled 108 patients and showed an objective response rate of 33%. And then it received regular approval in that same setting in April of this year based on the results of the phase 3 ASCENT trial, which was a randomized study randomizing patients to receive sacituzumab govitecan or to physician's choice chemotherapy. The study enrolled 529 patients, and as shown here, the sacituzumab shown in the green or teal bar had an improvement in PFS when compared to physician's choice. So again, a positive study that led to the regular approval. Based on the success in the metastatic setting, there was interest in looking at this in the neoadjuvant setting, and our friends and colleagues at Mass General, led by Aditya Bardia, have in fact conducted a neoadjuvant sacituzumab trial, which they've called Neostar. This shows you the schema. Basically, patients receive the sacituzumab in the preoperative setting, then undergo surgery with adjuvant chemo being administered per investigator discretion. The trial has completed enrollment, and I think we would hope to get results sometime in 2022. I wanted to show this slide, which details a proposed mechanism of action of sacituzumab that might make it an attractive partner with immunotherapy. So one of the proposed mechanisms of action of the SN38, that's the payload from sacituzumab, is that it stimulates DNA damage, which leads to signaling through the STING pathway. Signaling through the STING pathway results in the stimulation of an innate immune response, which then favors the endogenous T cell response. And so when you have a T cell response, one of the things that those T cells can do is become exhausted. So there would be rationale for combining with pembrolizumab to keep those T cells active. And so with that is some sort of preclinical or preliminary data, Dr. Bardia and his colleagues at MGH are planning an amendment to their Neostar trial where they will look at the combination of sacituzumab and pembrolizumab in the preoperative setting. I also want to highlight a trial, Espera, which I am conducting with my colleagues, Dr. D. Michel and Dr. Talani, where we're looking at the combination of sacituzumab and atezolizumab in triple-negative breast cancer patients who have residual disease and cell-free DNA after neoadjuvant chemotherapy. So the trial schema is shown here. It's enrolling patients who receive preoperative systemic therapy, have residual disease, and then are found to have circulating cell-free DNA. The treatment plan is shown here, and the primary endpoint is to look at the clearance of that cell-free DNA. This is a small study that will enroll 40 patients with the intent being to inform whether there would be utility in conducting a larger study. With respect to another target in triple-negative breast cancer, I'd like to speak briefly about BRCA, both 1 and 2. So we know that for our BRCA mutation carriers, that the PARP inhibitors, olaparib, as well as Telesoper are approved for use in the metastatic setting based on the Olympiad and Bracha trials respectively, both of which showed that the PARP inhibitor led to an improvement in progression-free survival. More recently, at ASCO this past summer, in a manuscript subsequently published in the New England Journal, we had the results of the Olympia Trial. So this is a study that was looking at olaparib in the adjuvant setting. So you can see here that patients could enroll if they had neoadjuvant or adjuvant chemotherapy to be randomized 1-to-1 to olaparib or placebo, with the primary endpoint being invasive disease-free survival. And of course, the trial was a positive study with an improvement in that IDFS rate, hazard ratio 0.58, highly statistically significant. And so based on this, olaparib is now being routinely used in the adjuvant setting for our BRCA mutation carriers. This is a subgroup analysis of the Olympia trial, and what I would highlight here is that the benefit does, it seems to be most significant for those in the triple negative although this is just, again, a subgroup analysis to point out, given our subject today of early triple-negative breast cancer. Given the success in the metastatic setting and the adjuvant setting, of course, there's great interest in thinking about PARP inhibition in the neoadjuvant setting. This is a table that shows a number of studies that have looked at it. Studies that have looked at veliparib, first I-SPY 2, and then the Brightness trial, and then talazoparib. And I want to focus on talazoparib because I think this is an interesting trial design that was championed by Dr. Jennifer Litton at the MD Anderson Cancer Center. So what Jennifer and her colleagues at MD Anderson did was initially a talazoparib window trial. So in this study, patients with tumors a centimeter or larger, clinical stage 1 to 3 that had a germline mutation, received talazoparib prior to their neoadjuvant chemotherapy. The trial's primary objective really was feasibility to see if they could accrue 20 patients and whether or not this regimen would be well tolerated. The trial met both of its objectives, enrollment and toxicity, and the median tumor volume decrease is quite interesting. It was 88%. So based on this, the next study that these investigators performed was looking at neoadjuvant talazoparib as a single agent. So you can see the schema for their second study here, talazoparib given 1 milligram orally daily, then surgery, then systemic therapy of physician's choice. The primary objective was the PCR rate. And so what they found was that a PCR was experienced in 10 out of 19 patients, so 53%. And if you look at RCB1 in addition to pathologic complete response, then it was 12 out of 19 patients, or 63%. And so these data informed a subsequent multi-center, non-randomized single-arm phase 2 study called NeoTala. This was a similar trial in that patients received preoperative talazoparib as monotherapy followed by surgery. The goal was to enroll 112 patients. The study was actually presented at ASCO again this past June. You can see here effectively a consort diagram, 192 patients screened, 61 assigned to treatment, 61 available for their intention to treat analysis. I would note that all 61 patients assigned to treatment did have triple-negative breast cancer, and shown here is the pathologic complete response rate, both by central review and by investigator. And so you can see pathologic complete response rates to single-agent talazoparib of about 45%. So from this, the investigators concluded that talazoparib monotherapy is in fact active in the neoadjuvant setting, and they also confirmed that it was well tolerated with 36% of patients experiencing grade 1 treatment-related AEs, 15% grade 2, 42.6% grade 3, and only 1 patient with a grade 4 toxicity. And the reason I find this trial so interesting is that it suggests to me that if we can identify a specific tumor's Achilles heel, in this case, the BRCA mutation, and target that, perhaps that's a strategy to pursue as we think about tailoring treatment for patients with early-stage triple-negative breast cancer. So with that, I would like to conclude my comments today by suggesting that an improved understanding of triple-negative breast cancer heterogeneity, an appreciation of the cell intrinsic as well as the cell extrinsic features, combined with a whole host of new or novel drugs, really has presented an increased opportunity to target triple-negative breast cancer. Neoadjuvant immunotherapy is a new standard for stage 2 to 3 triple-negative breast cancer. As I mentioned, I think there are a number of questions that arise to be further investigated about immunotherapy, most notably which patients require it, what are biomarkers of response and toxicity, and for those experiencing a PCR, who needs that full year of immunotherapy. PARP inhibitors are in fact the standard for BRCA mutated tumors. So what's the future? Personally, I think there's an opportunity for further characterization. So beyond the ER/PR/HER2, the characterization that I've alluded to today, as well as additional studies to be performed, will in fact allow for us to target specific pathways and vulnerabilities, as well as aspects of the microenvironment. And with that, I'd like to thank you for your kind attention, and I look forward to the Q&A. Thank you.